everyone. I'm Dr. Mohammed from Erbil, Iraq. Okay. I would like to thank the GIS community and special thanks for the chairman and Dr. Muthanna Quraishi. My subject is rather somewhat unusual and strange. I put this case just for discussion. Not necessarily I did a correct and wise job. Under the topic, should I occlude a non-functioning ectatic graft? My case is an elderly female, 71 years old female, diabetic hypothyroidism. She did CABG 4 years ago. They did Lima to LID and SVG graft to the circ and SVG to the right coronary artery. She presented with NASTEMI with chest pain for days duration, 3 to 4 day duration. So on examination, there is no signs of congestion and the was vitally stable. ECG shows non-specific inferior change, diffuse change, especially inferior leads. In the echo study, there's you see the lateral wall hypokinesia with preserved LV systolic function. The troponin was elevated, much elevated at 150, and she has single kidney, and the creatinine was border. GFR was moderate renal impairment. So these are the renal function tests. Okay. Because of renal impairment, we did a good preparation and nephrological consultation, adequate hydration. And we did later a CT coronary angio, which showed the graft to the circ OM is occluded. So we decided to do the PCI of the native circ. The CT scan is showed that the right is rather dominant, and the graft of the right is patent, and the Lima to LID is also patent. The circ is rather diffusely diseased vessel with severe stenosis. So we decided to do the PCI of the native circ as a culprit. So this is the coronary angio of the case. You see the circ is a very bad vessel, diffuse disease, fibrotic vessel. We can see much contrast staining, this contrast staining at the circ. This is cranial view. You will see that there's graft appears to be occluded with much a wide neck at anastomosis and aneurysmal dilatation. This another views. This the proximal part appears to be occluded and ectatic degenerated, and this the graft to the right is patent. This Lima is widely patent. PLID. This is the graft of the circ. We did the balloon pre-dilatation with the compliant balloon. It was a rather calcific and a bad vessel. You see the waist of the balloon. There was much calcium proximally, and then inflated. Then we upgraded to a NC balloon, 2.5, 12 NC balloon. We did a much pre-dilatation. Then we thought this is rather a debatable issue, whether to occlude this graft or not. Because given the wide neck and increased flow to it may increase the risk of increasing the size of the graft or rupture or something like that, we decided to deliver a cover stent to there. The cover stent is much bulky, will not deliver. Very, very, very difficult. Even I cannot accommodate a guide extension. So we delivered an Onyx stent drug-eluting just before the ejection of the graft. Okay, we inflated Onyx 225 by 22. This is the stent just before the ejection of the graft. We did post-dilatation. Then we did port. I deepened the guide so much because as Lima was protected, JL guide. Then we delivered the second stent also by the help of jailing wire. The second stent, 2 Onyx stents, 225 by 22, 225 by 22. Then through these stents, I delivered the cover stent. I was able to deliver the cover stent to the ejection of the anastomosis. cover stent 2.8 by 90. Then I inflate it at 50. This usually you inflate the cover stent at 50 pressure bar. We excluded the graft. This is the cranial view showing the graft is excluded. And we did port, and we deployed the third stent at the proximal lesion. This is the caudal, the spider view. This is the final views. This is the final cranial view. The graft is excluded. This is the result. So away from the subject regarding the graft master stent, the graft master usually the stents usually cover stent has two stents. There's a layer of PTFE between them, and it's very bulky to deliver. And it's available in size between 2.8 to 4.8. Usually more than 4 accommodate for a 7 French guide. Usually you inflate it at 15 atmosphere, but even higher pressure, up to 16 seconds, and use of by the use of the intravascular ultrasound, and prefer to ensure adequate expansion. You also post dilatation is very vital to completely oppose the stent to the visual wall if extravasation in case of perforation and other indication. I mean. This also we have PK papyrus, other cover stent. It's a thin polyurethane membrane. It's a much lower profile for crossing than the other. This is the stent. You see the 2.8 is the external diameter of the stent. If you go at 15 pressure, the internal diameter will be 2.1, and the external diameter will be about 2.7. Some indication of the cover stents for the coronary perforation, as you know, exclusion of the coronary aneurysm, although limited use, and exclusion of the coronary fistula, and for the SVG graft can be used, but inside, I mean, the graft, but especially if high risk of embolization. And thank you.